everybody for, can you hear me?
Yes.
Yes, welcome everybody and thanks for joining us. Before we kick off, a bit of housekeeping. We're going to be muting everyone to minimize the distraction. So today, Eileen Sandberg will be our host for the first session of the discussion panel, and will be taken over by our colleague. So Eileen, welcome, and please take over. The floor is all yours to welcome His Excellency to give the keynote speech.
Good morning, everyone. My name is Eileen Sandberg, and I'm the head of programs within the Global Engagement Directorate at Health Education England. And it's both an honor and a pleasure to be with you today. I have a very international background. So my father was a diplomat and I grew up all over the world. And so I spend a lot of time thinking about identity and home and how these concepts fit together. And for many of us, belonging to a diaspora is an element of our identity. It's an element of our personality, and it shapes everything that we do. And so I'm really thrilled to be able to be participating in these conversations about how we can bring our whole personalities to the work that we do in healthcare and reflect in our professional roles, whether that's as a nurse or a midwife or a radiographer or a healthcare manager, how all of our different experiences and backgrounds can make the services that we provide for our patients better and closer to their homes as well and their identities. So within the Global Engagement Directorate at Health Education England, we have an overriding purpose, which is to strengthen health systems and services in England and across the world. So we work with partners to attract and educate and train an international health workforce. And everyone on this call in their own way is part of that international health workforce, whether we work directly in health or in other systems. One of the key areas of activity for us is about offering global opportunities for the NHS workforce, because increasing the number and quality of global learning opportunities makes every one of us a better practitioner. It increases our worldview, it increases our experience, and so it's really key that we can bring those experiences to as many people as possible. And the diasporas have a particular home in that, because you already are coming at your professional practice with a worldview that encompasses more than one idea and more than one place. And that's a very, very powerful learning opportunity. But as we go through today, we're going to have a number of panel discussions on the work of various diaspora groups, on the impacts that these can have, and on some of the lessons that we've been learning throughout our first brush, although I'm sure not our last, with the novel coronavirus. But first, I am very honored to welcome His Excellency, the UK High Commissioner, Julius Peter Moto, to give our keynote address.
Okay, thank you, Chair, Ms. Eileen Sandberg. I hope I pronounced it correctly. We welcome you all to this important event, which is codenamed African Nurses and Midwives in the Diaspora, addressing COVID-19, and of course, other diseases. Now we are going to start our diaspora engagement. This is a good beginning. I think this is the first of its kind. And on my own behalf, and on behalf of Uganda government, and of course, fellow diasporans, I welcome all of you and everyone who is online attending this important engagement. I'm particularly happy to see that a large number of diaspora nurses, midwives, and professionals participate in activities of Uganda Nurses and Midwives Association. I think this is an initiative which is less than a month old, and I can guarantee you, Uganda High Commission and government of Uganda in general, we are happy to associate through associations like this, you will be able to make your voices heard, and you will be able to share knowledge and experiences in your various disciplines. In the last couple of years, we have seen nurses and midwives raise their profiles and standards. And I was happy to support. I was physically present during the launch of a global campaign called Nursing Now. Nursing Now was launched in London, and actually the initiative is now spreading across the globe. Nursing Now is a 3-year global campaign. It started in 2018. Up to this year, we are still making sure that the campaign goes on. It aims to improve the health by raising profiles and status of nurses and nursing worldwide. Run in collaboration with the World Health Organization and the International Council of Nurses, Nursing Now seeks to empower nurses and midwives to take their place in the heart of tackling the 21st health challenges. And now we have been faced with COVID-19. Nobody thought about it when this campaign was launched. It aims to maximize the contribution of nurses to achieve universal health coverage, of course, including COVID-19. There are 5 core areas, but I will not mention all of them. One of them is to ensure that nurses and midwives have a prominent role in health policy making. Everything starts with policy. You have to ensure that your voices are heard. It doesn't matter whether you are inside your country or abroad, but you should make sure your voices are heard through research and documentation of best practices and send it back home to Africa, where your services are much needed also. Your knowledge abroad is very critical in improving the health services in your home country. And of course, where you are in the UK and in diaspora. Our nurses and midwives in Uganda continue to work extremely hard to support Ugandans, especially during this coronavirus pandemic. It's a very big problem. And our health workers, including nurses and midwives, have been overstretched. They are increasing standards day by day, and they are trying their best. Therefore, it is great to see the diaspora nurses and midwives in the diaspora coming together and discuss the issues that affect them so that we can improve service delivery and move ahead. Government of Uganda values you as diasporans, and I believe that your experience and knowledge will impact positively here in UK, because that's where you are. Make your value be felt, stand above the crowd. And of course, in Africa and also in Uganda, we need your services, we need your knowledge. Share it with us. You may not be physically present, but I tell you, your shared knowledge can go far and wide. I am always a champion of this idiom that knowledge not shared is a useless knowledge. If you have knowledge and you don't share it, it's completely useless. So I urge you to share your knowledge and experiences, best practices with your countries back home in Africa. Once again, I thank you all of you who have taken time off, Ugandan nurses, African nurses and midwives in the UK, Uganda-UK Health Alliance, Public Health England, Health Education England and Tropical Health Education Trust for this great program that I'm happy to associate. I wish you good deliberation today. Thank you.
Thank you very much, Your Excellency, for the time and for the inspiring words. And always so wonderful to hear what an impact our doctors and nurses and midwives are having, both in the UK and in their home countries. I'm going to hand over to my colleague Helen Slattery now, who is the head of our Uganda programs, and she will be introducing our panels. So Helen, over to you.
Hello, I'm delighted to be joining you all. I hope you can hear me okay. My name is Helen Slattery, and I'm a colleague of Elin Sandberg's. I work for Health Education England in the Global Engagement Directorate. I'm fairly new to the Directorate, but I've got a long-standing history of working with Uganda. It started with a training course that I did in the north, in the Regional Referral Hospital about 10 years ago. So I'm delighted that I still have that relationship with Uganda, and I'm delighted that I'm here at this meeting today. So it is my job to introduce panel 1, and this is about where the diaspora can make an impact back at home. So we have Dr. Hajati Safina Musene, I hope I've said the name right, Commissioner of BTVET and Chair for Nurses and Midwives, Think Tank Uganda, and Dr. Rose Clarke Nanyonga, Vice-Chancellor of Clarke University International and Committee of Nurses and Midwives Think Tank. So I will hand over to you.
Thank you very much, Helen. I don't know if my colleague is here.
She is, but I think you need to, Eugene, you may have to bring her into the panelists, but okay, she has joined.
Let me check.
I think she was scheduled to go first. Should I go first as they are bringing her on? Yes, right, please. I see Helen shaking her head. Okay, brilliant. I'm delighted to be here. Your Honor, the Ambassador, and all invited panelists are all protocol observed. Thank you very much for including me on this very important panel, and congratulations to the Uganda Nurses and Midwives Association, the UK chapter, for successfully establishing themselves and quickly getting us all on board. My topic today is about engaging the diaspora opportunities for creating impact in Uganda. I'm very happy to be talking about this because I'm a returning diaspora individual who lived away from Uganda for nearly 20 years and returned back to Uganda 5 years ago to take this job as the Vice-Chancellor for Clarke International University. One of the things I would like to start with is actually, before we engage, before we even think about how we can make impact, I wanted to highlight a couple of things that were driven by my own experiences. The first is the mindset, being cognizant of the diasporic behavior. I remember when I first came back here, I was really eager to make an impact. I was really eager to engage, and I could see a lot of problems for which I had solutions. And I quickly became quite frustrated because the velocity and the pace with which things were happening on ground in context was quite different from my completely different socialized way of solving problems in the United States. And I think as Ugandans living in the diaspora, we do not even realize how quickly we change and how socialized to adapt to the American or the UK culture or the European culture. And in those many years of living away, we become slightly different individuals. Often we are a lot more skilled than the persons we are working with on the ground. We see solutions, but we do not actually see how we can implement those solutions. So I think that starting with our mindset, if we want to be successful in a sustained engagement on ground, we need to recognize how we ourselves have changed. The second thing is resisting the temptation to secure quick solutions versus working towards the sustainable engagement with local organizations. I remember once going to an orphanage and, you know, running off a lot of what I thought were quick solutions to the problem. Let me give you an example. I was working with a school-driven program around the country, and they had a solution for young girls to stay in school. And the solution was that they needed menstrual pads. And I thought, oh, this is the quick solution, you know, let's provide menstrual pads for these children so that they can stay in school. And 2 years later, I went back to assess the intervention.
You can give me a code.
Sorry, can everybody mute their mics, please? So I went back to assess the solution and quickly realized that the girls were still not attending schools at the same rate as the boys. There were still a lot of dropouts. They were spending a whole month during the term at home due to menstrual issues, even though we had provided the pads. So I sat down with the girls under a tree and I said, what seems to be the problem? Why aren't you able to stay in school? We have provided these pads. And it took a while before the pin dropped when they said, oh, but Dr. Rose, the pads do not stay. And I thought, what do you mean the pads do not stay? Now, I'm a child who grew up in the village. You know, I probably should have realized that, you know, if you provide the pads, they have to go along with panties. So for 2 years, we had a solution that was not working because we hadn't taken time to actually explore what else could it be influencing the solution we have provided. So we need to be able to resist the temptation to secure quick solutions. Understanding that we are not going to solve every problem is actually really important, so we can optimize the resources that we have to be able to link those resources to a specific need. Engaging for impact. Here, I wanted to talk about two important issues: mapping the diaspora skills and linking them to the skills needed on the ground. And this is work that needs to happen between the two groups. The diaspora in the UK, the diaspora in Canada, and in the US need to be able to organize themselves. And it looks like that work is already actually happening. But we need to do a second level of mapping and linking. What are the needed skills on the ground? And that requires us to collaborate on doing a landscape assessment, which is my next slide that I'm going to be talking about. But the other critical issue that has emerged during this time of COVID is how investing fast in technology as a means to mobilize and accelerate our engagement and impact is critically important. We need to be able to enable people, process, and infrastructure. I've sat in a lot of webinars where the cohorts in Uganda can hardly make a sustainable engagement on a webinar because the videos are not viewable. The internet infrastructure is not adequate to allow them to be able to engage. The network is really, really poor. So we have a way for us to accelerate means of engagement and impact, timely communication, and so on and so forth. But as long as there is a mismatch in the way we are able to engage with each other, if we cannot have a proper conversation using technology, then it's going to take us back to where we were before, where we are not, it takes a couple of weeks before a letter arrives in Uganda. The next slide is about landscape assessment. To become a significant actor here and exert focused influence in context, we need to seek first to understand what are the problems on ground. The second level of landscape assessment is enlisting context experts to be able to navigate people, culture, politics, policy, and power. For example, in terms of nursing and midwifery, we have the Uganda Nurses and Midwives Council, we have the Ministry of Health, we have associations of nursing and midwifery in various capacities. We have the nurse and midwives leaders think tanks. We have private entities, development agencies, embassies, other civic associations. More importantly, we need to understand how these are linked and networked and what is the nature of operating relationships, who influences whom, for us to be able to have a quick landing, you know, to implement whatever the solution or the agenda that we have. And also establishing or defining our path for influence and in negotiating and renegotiating engagements. So identifying strategic partners who are playing where we want to win would become really important. And then my last couple of slides really is, where then can we make an impact? I think for now, in terms of the short term, engaging to combat global pandemics, that's already actually happening. Hence this kind of webinar. So COVID-19, as everybody has said, is going to be with us for a long time. So we need to explore opportunities in which we can continue to bolster the ability of nurses and midwives in context to continue to provide care and enhance outcomes for Uganda's populations. The next level of engagement really is related to that in terms of global pandemics, NCDs. Prior to COVID, we knew that this was going to be our next explosion. And there are a lot of NCD level engagement that requires nurses to engage. Nurse-led interventions have been critically important in driving outcomes in other countries. That's an area where we can explore. Skills and knowledge transfer. A good example here are some of the organizations that the ambassador already mentioned. There is another organization called the Carnegie Africa Diaspora Fellowship, which basically sends Ugandans in the diaspora back to Uganda for a period of 3 months to be able to live within context, co-construct solutions, co-construct, understand the problems, and then devise a way to enhance the capacity of the people they are leaving behind to be able to deliver those solutions. The other issue really is the standing remittances to sustain NCD care through access to insurance cover. And I think that the way we send money home, you know, has historically evolved and it has changed. So we can be a little more targeted. I want to mention one issue. The ambassador mentioned the Nursing Now campaign and its agenda. But there is one report that recently came out, the State of the World Nursing Report, that prioritizes 3 specific things that where I think the diaspora can focus some of their energies in the next few years. Investing in nursing education, investing in their jobs, and investing in leadership. So those are 3 broad domains, including the Nursing Now domains of focus, where we can prioritize and say, okay, how then can we do this and how can we accelerate this? And finally, policy, lobbying for obstacle removal to enhance shared opportunities. One of the important way to engage here really is to recognize what existing policy is actually an obstacle for diasporas to engage in Uganda, and then organizing ourselves to lobby either to remove that obstacle or for a policy change to create an enabling environment to allow shared opportunities to occur. And finally, I think I've run out of time. supporting returning diasporas. I've been running assessments and surveys to see, you know, how many people are willing to actually come and settle back in Uganda. There are a lot of challenges, of course, when you've spent so many years away from the country. You have a family to worry about. People worry about career opportunities and progression in those careers and threats to those careers. People worry about having a soft landing when they come back here. But, you know, I think that if we really want to make impact, we want experts here that can be supported. We want to be able to create an enabling environment for diasporas who are willing to return in the country and support them to sustainably implement the agenda of the diaspora away from Uganda. So I think that's one way for us to engage. And there are a lot of nurses who really want to return back to their countries, and midwives as well. So this is one way we can really support those people to make impact. I thank you very much for allowing me to be here today. Back to you, is it Dennis and Eugene? Thank you very much.
Thank you very much. I think your colleague was going to make a presentation, if I remember correctly.
Yes, she's on the line.
Yes. In the meantime, could we kindly maximize the screens, because some of the participants usually have phones and we can't see your fantastic slides were a bit, yeah.
Hello.
Thank you very much, Dr. Rose. Are we ready for our next speaker? Do we have Dr. Hajati?
Yes, she's on the line.
She's on the
Yes,
line.
I am on
Thank
the
you,
line.
Helen.
Hello, are you able to hear me?
Yes.
You are able to hear me. Good morning. Let me assume that in UK it is still morning hours, though here in Uganda it is afternoon. I'm sorry that I had another meeting in State House, and that's why I've late to join this discussion. However, I'm called Safina Musene, and I'm the commissioner responsible for business, technical, vocational education and training in the country. We are nursing at certificate and diploma course. But I'm also the chair for the nurses and midwife leadership think tank. And I was contacted by the association to make a presentation and specifically to talk on how the nurses in diaspora, nurses and the midwife in diaspora, how we can engage them and how they can help the country. I have started my presentation by trying to remind us how nursing education started in the country. In 1919 at Mengo Hospital, that's when the missionaries introduced modern nursing in the country. And as we are now, I thought my slides would be projected. I'm not seeing them being projected. Chair, is that okay?
Yes, it's on now.
My slides, are they now projected?
Yes.
Yes, I was not seeing them okay. Okay, I was not seeing because it has been minimized. Okay, now I can see them. Okay, you can go to slide number 2, where I'm talking about how nursing education started in the country. And in the country right now, we deliver nursing in the government, in place-based organization, and also in the private sector. The country has over 10 universities and over 100 nursing schools that offer certificate, diploma, degrees, and postgraduate training. The service delivery is provided from health center up to National Referral Hospital, and now our oldest referral hospital, Mulago, has become a specialized hospital. We have a quite number of associations, but of recent we are coming up with a major association that will bring all together the various associations and the various nurses in various capacities to enjoy socialization. Education in the country is managed by the Ministry of Education and Sports, while the Ministry of Health manages the delivery, but at the same time provision of policy in relation to nurses and midwifery and all the health care delivery issues. And the Uganda Nurses and Midwives Council do the regulation. In April this year, when COVID-19 became a reality in the country, the nurses, the leaders decided to form the Nurse and Midwife Leadership Think Tank, which was formed from leaders from the various sectors, Ministry of Education, Ministry of Health, universities, and the private sector, hospitals, and the rest. Now, why Nurse and Midwife Leadership Think Tank? This was formed majorly to advocate for support of nurses and midwives across the country during the COVID-19 era. It was formed to work together with the National Task Force, ensuring inclusive, reasonable contribution for the nurses and midwives, and to enable them to be part of the planning and management of the pandemic. To advocate for equity as far as compensation and facilitation allocation at the front line of health workers, including the nurses and midwives. We want to register as nurses of Uganda and we who are in the think tank that through this strategy, we have been able to hold several meetings. We have been able to develop, initiate a newsletter, which we have been delivering every other week, but now we agree that it will be a monthly newsletter. We have held a webinar where we had various discussions, including key stakeholders at the Ministry of Health, responsible for clinical service, responsible for maternal and child and the quarantine. We met the Permanent Secretary, Minister of Education, and this one was mainly the Minister of Health. This was mainly to discuss with her the challenges nurses and midwives face. But on top of that, by that time, we did not have a head nurse at the Ministry of Health. So we went to advocate for a leader for nurses and midwives. And I want to share with the rest that we are able, now we have a substantive appointed Commissioner Health Services in charge of nursing and midwifery services in the country. A survey was conducted which guided most of the actions of the think tank, especially the inadequacy in the personal protective equipment, and where we again made our focus as leaders to fundraise and manage to buy personal protective equipment was a huge Uganda shilling, about 19 million. And we are continuing with this strategy to continue fundraising for the nurses, continue advocating for them, and continue holding our weekly meetings and so on. May I go to the next slide? Yes. Now, this was the question that was asked: how the Uganda nurses and midwives in diaspora, and these who have made themselves into an association, can benefit the Ugandan citizens. I read through the document that was provided to me, and I appreciated the mission of this organization, of this association, of being a vibrant and supportive organization promoting nurses' special contribution to the Ugandan population, both in the United Kingdom and in Uganda, and also to speak to the welfare and advancement of values of nursing development through education, networking, support, professional excellence to enable optimal care. I want to say that that mission is a mouthful, and it is, of course, taking me to what is forming my discussion in this. May I request for the next slide? Yes, how this one is a coordination. All of us, we do appreciate that vital resources for the development of any country is its people, both those ones who are at home here, but also those ones that are abroad. And also appreciate that it is very important to mobilize nationals abroad towards the development of their country. Wherever you are, you always have your original country as part of you. And whatever happens in Uganda do affects you. Whatever happens in the United Kingdom do affect you. So considering those two factors, they lead me to the discussion that I'm going to present in the next slide.
Dr. Safina,
yes,
may I interrupt? You probably just have a few more moments before we need to move on to the next panel.
Yes.
We just have a few more moments before we need to move on to the next panel.
So I hold on this one, I don't present this next slide?
I think we would like to hear this one, please.
I present this one. Okay, let me quickly go through this one. So our expectation as a country, we know that you do send money to our country. So we want to encourage you to continue sending that money, but also want you to invest in Uganda and majorly in the health sector that will support service delivery in the country. We expect the nurses and the midwives to help the Ugandan nurses to be connected to available opportunities in the UK and elsewhere as they improve their capacities. We expect promotion of nurse and midwifery knowledge exchange, transfer of skills. I heard Dr. Rose talking about transfer of skills and technology, and especially right now with COVID-19, we want to see how technology can be used in service delivery, in education, in all areas that concern nursing and midwifery, research, administration, and management, and so on. We want to promote friendship and cooperation between the UK and Uganda and through your personal contacts and networks. And we want to initiate an avenue not known to you, but for the betterment of the nursing and midwifery fraternity, and last, to support the Uganda Nursing and Midwifery think tank to achieve its objective. That was I think the second last slide, if I can see. The last one was about appreciation chair. I just wanted to appreciate our Ugandan High Commissioner, His Excellency Julius Moto, and the association and all the panelists, and Elizabeth Pearson, who was on me to ensure that I make this presentation. Chair, thank you very much.
Thank you. I'd like to thank Dr. Rose very much and Dr. Safina for their presentations. Very insightful. I found it very interesting, Dr. Rose, to hear about how we may think of a simple solution, but actually, practically, we will then find that it doesn't work. And it's a good lesson to us to think that maybe a quick fix isn't the right thing to do, and to make sure that we understand context before we go ahead and develop.
I think we have lost Helen. I can't hear her.
Hi, Helen.
She's back.
She's back on another one.
Helen, if you could unmute yourself. There she is.
Okay. I'm now on a different camera. I'm having internet challenges. Sorry you lost me just then. I was just thanking Dr. Rose and Dr. Safina. I thought that having the Ugandan Nurses and Midwives Association linked with the UK shows us a way that we can work together when people are looking for avenues of how they can contribute. And I felt there were some very useful suggestions within there. We move quickly to any questions and answers. I'm struggling to see it on my laptop because I'm just on my phone.
Do you want me to
wonder if
read it?
someone is able to read out.
Yeah, the question is from Sulaiman Subuga. And this is from Sulaiman Subuga, dental hygienist, focusing on mouth hygiene link to the entire body. I have a feeling that the mouth is always separated from the body. Holistic approach where the whole health, including mouth health, is important to achieve general health and well-being. My question is to the ambassador and the health ministry in Uganda. When will dental hygienist professionals be introduced and recognized in Uganda?
Okay, that's a very good question. Have we someone on the panel who is able to answer this question?
Well, I think that's a very good question. On the health forum to which I'm a member, the dentist, the expert dentist actually keeps on advising us that the most important part of our body that we should keep clean is the mouth and the dental hygiene. And he actually sent me a text message that if you keep your dental, if you keep your teeth and mouth very clean, you will rarely fall ill. I have his messages. I think this is an area which government of Uganda has taken keen interest in. It is not neglected. It is part of our health sector strategic plan. And dental problem is a very big issue in Uganda. Almost, I don't want to speak in terms of percentages, but I can tell you, almost everyone has it. But it's a very big problem. Although there's little information or lack of education about it. And this is something which we are going to take up very seriously. I appreciate your comment. Thank you.
Thank you very much.
May I make a comment?
Yes, please, Dr. Rose.
Well, thank you very much. Thank you, Your Excellency. I also wanted to just mention that the Uganda Medical Association, as well as the Allied Health Professionals Council, those two bodies exist, and the Uganda Dental Association also exists. I do believe that there are dental practitioners in the country now that prioritize dental hygiene. The training of dental hygienists hasn't started yet, but those are three organizations at least where we can tap into and inspire the start of this training. So in terms of lobbying, I just wanted to point that out, that you could reach out to those organizations. Thank you.
Thank you, Dr. Rose. That's really helpful.
Helen, there's a second question. Do you want me to read that as well?
I wanted to say something. I wanted to say something about that, moderator. Nursing and education is under the Ministry of Education and Sports. And right now we have a policy that if a need is in the community, in the sector, then such a curriculum is developed. I want to say that I'm going to take this one as a take-home message that an issue has been raised for dental hygiene and the curriculum must be developed. One of the institutions where many diploma practitioners are produced under my docket, and we shall discuss it in the department, but also I will request Dr. J. Rose at university level, which again I will discuss with some dean of medical colleges to see that it is taken over at bachelor's and maybe postgraduate level. But for the diploma level, I will take that and I will discuss with the sector, Ministry of Health, for that curriculum initiation.
Thank you, Dr. Safina. I think at this point, we need to move back to the schedule because we now have panel 2. Panel 2 is lessons from the African Diaspora, Nurses and Midwives associations. Each panelist will have 7 to 10 minutes for their talk, and then I may interrupt. So I think first we have Rose Hombo. She's the head of nursing, Oxford Health NHS Foundation Trust, and she's the president of the Cameroon Nurses Association in the UK. So I'll hand over to Rose.
Hi, Helen. Hi, everyone. Can you hear me? Okay. I can see your head, you're notching your head, Helen, so I take it everybody can hear me. I'm Rose Hombo, the head of nursing, or should I say the divisional head of nursing for Oxford Health. And my background is, I'm a mental health nurse by background. I'm not standing here today as a representation from Oxford Health, but I'm standing here as the chair of the Cameroonian Nurses Association UK. Again, it's worth saying I've just become the chair, so I've just been elected the chair as early as February. So I haven't really done much as a chair, given the current COVID situation. But I'm really glad to be here, and I've listened to some of the discussions or the presentation that has taken place. So I was asked by Moses to come in and just, think about what we do, and if there's any advice or support that we can offer for the new organization that is just starting. So from my experience, in terms of Cameroonian Nursing Association, so it is, again, we are a very small group. We also very newly formed. Our main objectives is building strong, sorry, I'm echoing. Okay, our main objective as a diaspora group is building strong connection between the Cameroonian nurses, midwives, health visitors working in UK with links back in Cameroon, and also trying to influence policy and legislation in the UK that would support some of the diaspora group in Cameroon. We are coming from a very different position compared to Uganda. In fact, I have to say, Your Excellency, I was very, very impressed to observe and see that you're part of this event. For Cameroon, it will be a completely different ball game. If I'm honest, I can't even remember that I have ever seen our High Commissioner in any of the events that we've done. That could be as a result of many things. As most of you would know, Cameroon is a bilingual country, so it's both French and English. And it is a country that is made up of 10 provinces. 8 of those provinces are French speaking and 2 are English speaking. And majority of us from the group, again, would be from the English. Cameroon colonial master would have been French. Again, so the way things are done in Cameroon would be completely or slightly different from the UK. And that would be from education to regulatory bodies. So the advice that I can give yourself as a new group is, you've heard most of it already, but in my experience, I think Dr. Rose picked up made a few sentences in her presentation. And the things that kind of resonate with me and resonate with the group as CNA is the word engagement, maximizing your resources, understanding your links, networking, and knowing what works in Uganda. Who are the people, which departments or contacts that you need to lobby to be able to get over any piece of work that you want to do. For the Cameroonian Nurses Association in UK, predominantly, our focus has been to, first of all, trying to increase and maximize our members. And again, it's developing the group and taking the group to the level that the group then understands the needs. So doing an exercise around what are the needs from Uganda or from Uganda healthcare, and how then can you use the resources or use the expertise that you have as a group to influence or support where the needs are. And majority of it would be, again, most of us who are nurses will know, and if you work in, if your passion or your sort of expertise is around governance, you will know that most of the things that you do will probably be strategically influencing decision and getting yourself to positions where you're then able to influence those decisions and work with people. Mindset is another thing that Dr. Rose mentioned that is really, really useful. Having a group where, again, in a new group, you have people with different levels of expertise, different levels of mindset. But if you can build that group culture and that focus, that your mindset and your aims and agenda are very clear, and then you're able to, develop your group to be able to work towards your goal, I think that helps a lot. So in terms of the kind of advice that I'll give you from my own experience, one of the things that happens currently with COVID, we all know that COVID is a very, very bad situation. But I will always say, and some of you in the group this morning will know that for me, with each challenge, it's always an experience to learn from. So regardless of the fact that COVID is a very bad situation and people die from it, I will also say it's giving most of the diaspora, particularly Cameroonian Nurses Association in the UK, that window to be able to work with the local communities and communities back home to actually physically contribute positively in changing the bad situation that people are in. And some of the things that we've done during this COVID period was reach out to, the reason I spoke about Cameroon being a sort of bilingual country is that currently we've got quite a lot of political unrest in Cameroon. So there is a group of the French-speaking, English-speaking side that has moved on to as refugees to Nigeria. So during this COVID period, we are working in Nigeria rather than in Cameroon to influence those camps and support those camps practically with basic healthcare facilities and resources, just to make sure that we limit the amount of death or infection that is walking around camp. So using COVID as an example, maybe if COVID didn't happen, we would not have moved so fast to support those camps and those refugees. And then back in UK, what we're doing currently is then working with some of our local hospices, because we know that that's where the needs are. So we've got nurses from the group going into those hospices to offer practical support. So the advice that I will give you is, there would be challenges. You've hit the first goal because you absolutely have got a buy-in from your ministry, and you also have got a buy-in from your High Commissioner. So that is a good start. And I think you just need to strengthen those links and make sure that those people are involved in all the pieces of work that you plan to do. And I think I'll end there because I know I had only maybe about 5-6 minutes, and I'm not sure that exhausted my time. Be happy to take any questions.
Hi, Helen, can you hear us?
Yes.
Helen. I think we've lost Helen by
issues again.
Yeah. We've lost Helen, but in the interest of time, probably we move to Wendy.
Sorry, I think I have to join you on my phone again. Only one question has come up, and it's from George Abraham, and he was asking whether there are any courses that health people are using from the UK that are being shared, from the diaspora, that are being shared to Uganda. I wonder if any of our panelists are aware. I myself, I'm not sure which courses exactly. Some time ago, there was a course around acute illness management that was being delivered in Gulu in the north of Uganda that I'm familiar with. And recently there's been in Uganda antimicrobial stewardship courses that have been shared between UK and Uganda colleagues. So those are two that I'm aware of. I'm not aware of others. Has anybody got any experience?
I think, Helen, if I could just say, for the Cameroonian Nurses Association, we haven't got a course per se, but what we have is a library, electronic library resources, which we are supporting. So a company provides that. So we have bought it and then pay for different modules. It's almost like electronic university. And so our nurses and midwives from Cameroon, students, could actually tap onto it. So we are funding it for it to be used back home in Cameroon. Okay. So I don't know whether it's something that I could share with the Uganda Nurses Association, if that's something that they might be interested in.
Yes, please.
Okay. Thank you. I'm going to move on now because of time necessitates this. I'm hoping we have now Wendy. Maybe you can help me with your surname, Olayiwola, Senior Midwifery Manager at Barts Health NHS Trust, Newham University Hospital, and she's also the President of the Nigeria Nurses Charitable Association UK. Over to you, Wendy.
Thank you very much, Helen. Can you hear me?
I can.
Fantastic. Thank you very much. I'm glad to be here today, and what a fantastic opportunity to network. And Moses, thank you for inviting me. Just as Rose said, I'm also here in the capacity of representing Nigerian nurses, and as my role as Nigerian Nurses Association, not representing my trust at all. Right. Just as Rose also said, we were asked to just talk about ourselves, Nigerian Nurses Association, who we are, what we are, our impacts, and obviously also how Uganda Nurses Association can learn from us. And at this junction, I must say congratulations to you guys and welcome on board. It's a good thing to do and it's the right thing to do. And also congratulations that you actually have your High Commissioner right beside you. It really means a lot. And thank you very much, sir, Your Excellency, for the support that you are giving to the Uganda nurses and obviously across the board. So who we are, Nigerian Nurses Association was established over 22 years ago, precisely in 1998. And we have a charity status, and our membership includes nurses, midwives, and health visitors. And we do represent over 3,000 members. We celebrated our 20th anniversary a couple of years ago. And because of time, I've got quite a lot of slides, but I'm going to just skip through them. That is our aims and mission. It's just very similar to you guys as well. Ours was set up to relieve the poverty and distress by the provision of practical contributions to delivery of healthcare both here and our home country, which is in Nigeria. We do have patrons and partnerships. Partnership is a key to survive, really, and it really needs to link to, it helps you to achieve your mission as well. So yes, we do have our Nigerian High Commission on our side, and it's actually anybody in the seat of being a High Commissioner is our first patron. And then we have Dame Professor Elizabeth as one of our patrons, and our our colleagues, Medical Association of Nigerian Doctors, we work in partnership with them a lot, British Nigerian Forum, Royal College of Nursing, you know, then we have an organization called Keynote, which is Central Association of all the Nigerians organizations in the UK, and we work closely with the NMC as well. Over the years, it has been a struggle. So do not be deceived. It's a hard work when you have your day job and then you have this voluntary work to do, and to ensure that you actually balance, support your colleagues over here as well as at home. So in terms of achievements, you know, a step at a time, it's really been a challenge. Sometimes we went quiet because everybody is busy, and then we, you know, dependent on whoever that is actually coordinating the whole activities, then depends on our achievement. So over the years, we've achieved a few things. Number one is community clinics in Nigeria and engaging all the rural areas, and also working with our colleagues in Nigeria. We do a lot of that. We do a lot of events here in the UK. We make at least about 2 to 3 every year. Yeah, I will probably mention that in the next slides. You know, in terms of events in the United Kingdom, we do diaspora events. And like I said earlier on, we have a strong link with our UK Commission. And then we do have Nigerian Nurses and Midwives ambassador at home. We work very closely with the Federal Ministry of Health in Nigeria. And also we work closely with our other colleagues, you know, in the diaspora as well, the other Nigerian nurses and medical doctors in the diaspora. So we work closely with them, and we always tend to come together to do a joint medical mission or nursing mission, as it may be called. Again, every year for the past, I think we started this about 8 or so years ago, every year during the International Day of the Nurse or the Midwife in May, we now have a popular seminar that we bring all the nurses and midwives together, and you don't have to be a Nigerian. We just throw a seminar as well as like a networking drink, just to celebrate ourselves and appreciate ourselves and pat ourselves at the back. So that's been a popular event in May over the years. We also set up our young and new qualified nurses and midwives, like a mentorship kind of support. The young shall grow, just to catch them young and to make sure that we engage with that. And because we noticed over the years that there is a bit of gap between a couple of generations. So in case with some of us, I'm not just there yet in terms of retirement, but the people that some of us took over from have now retired. And so just to build the gap so that the organization does not suffer. Then we also set up a body support system for each other, and a global mentorship as well. And what do I mean by global mentorship? And that is the relationship between us here and in Nigeria. So what we did was NNC, and Nigerian nurses actually led on liaising with other Nigerian nurses, like Nigerian nurses in America. We have our colleagues in America, in Canada, in South Africa. So we kind of linked with them to provide mentorship for our colleagues in Nigeria. So that's what that is. Our 2020 activities pre-COVID, I did put there minus COVID-19 pandemic. So we already have our 2020 activities calendar lined up before the COVID. And that was in January. So we were fortunate that we achieved the January one before the pandemic broke. So in January, we had a capacity building where we went to 3 states in Nigeria to actually train and provide training and education for nurses. We actually I think our aim was to just provide education and training for about 200 nurses and midwives, and we had over 500 in attendance, and that was over 2 days, and it was really good. So there were 7 of senior nurses and midwives that went from here. We took annual leave, we paid for our own ticket. It was a bit expensive, but it was worth it. So we did that in January. And May was also supposed to be our joint mental health seminar with our colleague from British Nigerian Law Forum. We didn't do it in May, but we eventually did it in June. So we still tick the box for that. And the May International Day of the Nurse, that our usual thing that we're supposed to be doing, we didn't do that again because of the pandemic. And we also planned to have, been the year of the nurse and the midwife, we also planned to have a global conference back at home in Lagos, which obviously we had about 13 to 14 countries joined with us. So about 14, but not Diaspora nurses from 14 countries would have actually gone to Nigeria for the first time for a 1 week long conference. But obviously that is now on hold because of the COVID. Right, that conference was actually titled Nigeria 2020, the year of the nurse and the midwife. Everything was actually set for that before the COVID. Coming back to UK, so our UK activities during the COVID, I mean, I think after January, by February, March, that's the COVID hit all of us across the country, obviously globally. We just then now change. What is it? We look at the opportunity of what is it that we can do for ourselves, considering that, you know, it's more of BAME nurses and midwives that are dying at the front line of COVID. So we are the first organization that started a weekly webinar in 19th of May. And up to now, we still continue to run that webinar just to support. Initially was opened to nurses and midwives and subsequently open to all. So this was continued. That was for everyone, you know, across the country. And I must say that those that have made journey are not just from the UK, but across the world.
Wendy, I'm sorry, at this point, may you just wrap up?
I've got just 1 minute.
Okay.
Okay, that's fine. So those are the webinar that we have run through since April. I think we are now on the 11th one. So the 11th one is this Friday, where we are bringing all the regulators and the unions together to see, to talk about the effects of COVID on nurses and midwives. So just because I've got 1 minute, I'm just going to skip. And Nigeria, we also obviously engage with Nigeria a lot. So we did a webinar for them. And that was our webinar for Nigeria, supporting nurses and midwives. And the second one was on the management of infection control, where we have Public Health of England, you know, at the panel. So basically it was more of a global sharing on how to manage COVID. So just in summary, in terms of advice to you guys, we are obviously happy to work with you and show you what we've done well and what we could have learned from. And it's such a good platform to go. And we also actually have Commonwealth nurses that we talk. We have a WhatsApp group, and if you're happy, we can add you to it. So welcome on board. Thank you very much.
Thank you, Wendy. Thank you. We now, I hand over to Elizabeth Pearson. She's a registered nurse. She's the interim president of the Uganda Nurses and Midwives Association in the UK. Over to you, Elizabeth.
Thank you very much, Helen. I hope I'm audible enough. Yes. Hello, my name is Elizabeth Pearson, and I am the interim president for UNMA UK, and I'm going to present this on behalf of the interim strategic team. So thank you so much, Your Excellency, our patron, whose leadership and unity has enabled us to form an association. Our leaders here in the UK and in Uganda, our chair for this session, Helen, our lead stakeholders, Health Education England, our interim committee, and my colleagues. My background is a nurse, as previously shared. I'm currently Operations Director for Zone 1 Hearing London, founding chair of the knowledge sharing platform for nurses and midwives in Uganda. So I've had a good privilege of working both in the NHS and in the private sector. So why Uganda Nurses and Midwives Association UK, UNMA UK? Just to give you a bit of background, according to the Common Survey of 2016, there were 461 registered Ugandan nationals working for the NHS. So we are a big contributor to the NHS. Uganda ranked 8th among the African countries, beating countries like Sudan, who registered 434, Tanzania, 142, among others. Countries like Nigeria, of course, recorded 5,014 nationals, and Zimbabwe, 399 nationals. So you can see their report on the website. So we do have a good number of members. The point about the driven pandemic, regarding how associations are started, indeed for us, it has been no different. The current pandemic has had an impact directly on our small community, and we have lost many members, almost 30, some healthcare staff. So we recognize the need to form ourselves into an association and be able to give the best of ourselves. If we are well, if we are healthy, we can then give the best care to our patients and communities. May I request a moment of silence to all our departed comrades. May their souls rest in peace.
Amen.
So who is the association for? The association is for diaspora nurses and midwives residing in the United Kingdom, including our student nurses and midwives, our associate nurses, and our retired generals. We need your guidance. So it is to support us and to network professionally. What is our vision? That's our mission and statement that we are very optimistic we'll be able to meet, to develop a vibrant, supportive organization to prosper the welfare of ourselves, Uganda nurses and midwives, our healthcare assistants, our associate nurses, to advance the value of nursing development. I know our commissioner shared that widely. So hopefully you will be able and bear in mind our vision and help us achieve it. So what have we done so far? We have initiated a WhatsApp messenger group and hit the 100 mark within days. This is great motivation and spirit within our members. We are looking forward to our next steps, which will include, among others, completing the registration process. We have an interim committee with members with different leads, such as strategic development advisors, professional and practice leads, research and academia, where Herbert later is going to give you some brief account of some of our suggested activities. We've got community engagement leads, education and innovation, where Jackie again is going to share some good examples. We've got an equality and a diversity lead. We've got a well-being given COVID-19 and post-COVID-19. We've also got young nurses and elders, our generals. So it's a fully variety of skill mix with different level of education, and it's bound to make a great team. If you are familiar with a good meal locally made called katogo, you will know that if you have the right different ingredients coming together, it is a very delicious meal. So what would we like to do? Our next steps. As the interim committee, we are all volunteering and our time and expertise to build, to make a strong association, but we need support. We need financial setup costs. We need to be able to carry out our intended activities, both here in the United Kingdom and in Uganda. We need guidance, a lot of it. Thank you, my colleague Wendy and Humble for coming to share your experiences with us. And we need a lot of expert advice. There has been disparity in the current COVID-19 report, so we hope that the association will bridge the gaps in the healthcare among our community in the UK. We've had diaspora-led initiatives, successful projects that have had positive impact locally and globally. Examples of my colleague Primerose and Jackie are going to share. We would like the association to build on these examples. So as the association brings us together in diaspora, it is to have a bigger impact, both in the UK and Uganda and globally, as our ambassador shared. So what are the benefits? It is to bridge the gap of inequalities for BME. So for instance, if the government of England, set up some projects and they are initiated, the association would be well placed as a strategic body to help in the delivery for healthcare programs like immunizations, because we are there in the community as an outreach program for both micro and macro and macro settings. So the association boasts of having a healthy workforce, like I've shared, with a diverse skill mix. We've got leaders, we've got researchers, we've got innovators, we've got lecturers, we've got nurses, we've got midwives, we've got students. So it promotes belonging, because together and the outcomes would bring the learning back to our communities. So I'm just ending now. I would like to thank all the strategic team who are working tirelessly hard behind the scenes into the wee hours of the night. My colleagues, our leaders, and the international community of supporters. Strength in unity. Thank you very much.
Thank you very much, Elizabeth, Wendy and Rose, for your contributions. Now we will move on to our next panel, panel 3. And this is the diaspora impact back home and in the UK. We have Primerose Magala talking about the active impact in Uganda, a case of institutional collaboration. Primerose is a senior ophthalmology nurse at Moorfields Eye Hospital, and she's also the interim co-vice president of the Uganda Nurses and Midwives Association UK. So hopefully we have Primerose on the call.
Yes, I'm here. Thank you. Good afternoon, everybody. Thank you so much to the organisers, Moses and SSCG Consulting, working behind the scenes to make this happen. Thank you, Our Excellency, Ambassador Julius Peter Moto. Without your support, not much would have happened. Thank you to our host and chair, Ellen and Helen from Health Education England, one of the stakeholders, and it's the global engagement part. So thank you so much for that. We also thank Uganda-UK Health Alliance, who are very, very instrumental in making things happen. And the last one is Tropical Health Education Trust and others who are supporting our efforts. I also wish to thank the wonderful panelists for sharing and welcoming us to work with you. We thank the colleagues in Uganda and the leaders in Uganda and also here in the UK. And last of all, the audience. We thank you all and we hope we can move forward positively together. It is wonderful to have this opportunity because some of us have thought about this, dreamt about this, so it's wonderful to see it happen. So like Helen has kindly mentioned, I'm here to present about institutional collaboration between Uganda and the UK. It's an example of what we have tried to do, and probably had we had this platform way back, we would have done a bit more, so it's wonderful. And so as a diaspora nurse from Uganda, originally from Uganda, I came here because of circumstances. I came to the UK to live with my mother. And to cut a long story short, I ended up becoming a nurse because, you know, I had missed something. There was a gap following my previous job, and nursing has brought about satisfaction and completeness in what I love doing. So one of the opportunities I had as a student nurse was to have a placement at Moorfields, and it is at Moorfields that my calling came. I just felt that a light bulb had gone off. So I thought coming to Moorfields that I would be retiring there. However, looking at how things were done and then going back home, each time I went back home, unfortunately, it was somebody had passed away or somebody was unwell. So what I saw back home and then coming back here, I thought to myself, what can I do using the opportunity, using the employer where I am to support our colleagues and my people back home. And this is where iHealth Uganda started. So just using the opportunity, being a nurse, sometimes we're not heard as nurses. When you are among doctors, you're among, researchers. I think the nurse is, in the background. So it's wonderful to have this platform as nurses to achieve more. So at Moorfields, I discussed with a consultant to see how we could help Uganda. So the first thing was to engage. We engaged the Moorfields board. We also engaged Uganda. We tried to engage the national referral. Unfortunately, many doors were not opened. So we looked at another institution and Lubaga came on board. So we thank Lubaga for saying yes. One of the things we've had to do to get this agreement going is to sign an MOU or Memorandum of Understanding as an agreement. And we're thankful that that has been signed with Lubaga, but we're about to sign another one which will support the whole country. And the benefits are endless. The knowledge sharing, as the doctors, if you visit the website, the doctors will, talk about how they've done things in 4 days that they've never done in all their careers, for 7 years. So it's a wonderful initiative and it's having a global impact, as we shall see later on. So that's the journey. Yes. Yes, Helen? Helen? Sorry, Helen?
I think she's having technical issues, but I suspect it was about time.
Sorry, okay, the second slide, sorry, the next slide, please. So the next slide, so the next thing we had to do was establish a platform. So that platform would enable coordination between Uganda and the Institute Moorfields, and also other people who were interested in supporting us. So we established iHealth Uganda, and please feel free to visit the website to read more about what we've done. So one of the things we decided was to have a camp. So the first camp, we needed to start. So that camp was enabled through collaboration with UUKHA. So Uganda-UK Health Alliance was very strategic because it was a bridge combining the work of the UK organizations and Uganda health-related organizations. So we liaised with UUKHA, Lubaga, Moorfields. We decided to have the first camp at Lubaga, the host site, and that took place in 2017. The first camp was meant to be a screening camp only to test the waters as a pilot. So through people like Moses, I was able to link with other supporters, stakeholders who were able to donate equipment. So we went from a screening camp onto an operational camp. So we were able to perform cataracts. So in this camp, we saw over 1,000 patients, 1,150 patients, and we had to turn away almost the same number of patients. But what we learned from the camp was that we did not need to see all those patients at the same time. And this is where the knowledge sharing and skills exchange comes in. So in Uganda, you make do with the little you have. So we learned that. And we also learned that the doctors don't just work on eyes, they do everything else. And we also learned that the nurses were not as involved in the, like things like triage. So we're able to exchange knowledge to say, right, okay, at Moorfields, for example, the nurses can triage. So if you have 1,000 patients in A&E, probably 700 don't need to see the doctor. So the nurses can have those skills, triage, look after some of the patients, as nurse practitioners, and then the doctors can focus on the complex things. So you have professional development, health education, and things like that, adding to the capacity development, therefore bridging the gaps. Next slide, please.
Primrose, I'm going to have to stop you there because we have to move on to the next speaker.
All right. Okay. Thanks, Helen.
We do have an opportunity later on in a few moments in the questions and answers, and maybe some other of the points could come out.
Wonderful. Thank you.
Okay, thank you. So our next speaker is Herbert. Herbert, I'm really sorry, I'm not going to do your surname justice. Mwembi.
That's fine.
Senior lecturer at Middlesex University and the interim co-vice president of the Uganda Nurses and Midwives Association, UK. And he's going to talk about the diaspora nurses in academia and research. And Herbert, as you know, we are running rather short of time. So possibly you can tell us the main points.
I know.
Thank you.
Really lovely to be here. I'm not going to require my slides, but I just want to thank Helen and the chair and other expert speakers for a much value-added contribution to this event. Obviously, I know too well, coming in as one of the last speakers, that this has its challenges, because pretty much all the good points, I'm sure, have been made, which makes my job extremely easy. And that's me done, okay? But not quite. I've been asked to briefly talk about research and academia among us diaspora nurses, obviously in the UK, as well as using our tools and skills to be able to engage both our colleagues back in Uganda and elsewhere. As one of the objectives of the newly established, obviously, Uganda Nurses Midwives Association, I'm sure you all agree with me that we are living in exciting times. Obviously, aside from the current situation, we live in an era where there is cutting-edge research, which is at the forefront of research, as well as several medical nursing innovations which inform evidence-based healthcare. Now, we live in a very fast-moving digital information age where I believe data and information can have several benefits, including monetary benefits. As a new association, I believe that we would like to tap into this by using the much diverse clinical expertise within our group members, which I say obviously has been formed over the past couple of weeks. And so far we have over 100 members, which is really exciting times. But also we want to use those skills to engage in community interest projects, obviously to produce data as a reference for developing research proposals, as well as authorship of peer-reviewed academic papers, and use this as a feed forward to develop and engage our partners both here in the UK, as well as in Uganda and elsewhere. And also, if I may add, the current situation around COVID has rattled all of what we know as normal life. We have come to learn of so many new terms, concepts, and the internet has been awash with so much information, some of it quite authentic information, some of it fake information. So for us as the Uganda Nurses Midwifery Association, potential areas of interest where we would like to work with our partners and others would include issues around sort of socioeconomic disparities, obviously existing within the UK, but also globally in Uganda and elsewhere, mortality disparities due to obviously the current situation, COVID-19, and obviously the current sort of Black Lives Matter movement and Britain's colonial legacy and connections with slave trade. For me, these are all potential areas where we can sort of look at research areas that can be emerging for us to form a common agenda and look at how we can sort of engage our members around those areas. This obviously has a lot of potential to influence policy direction, both here in the UK as well as back home in Uganda and globally as well. The other thing, just briefly to conclude, Helen, and I know we're pressured for time, one of my roles at the university, obviously I teach across a range of different programs, but I engage so many people from diverse background. I work with so many people from diverse background. But one of the issues I think within the UK, as well as I'm sure you would appreciate, universities have a role to promote inclusive environment in which students and staff of all backgrounds and ethnicities can flourish. I mean, the evidence is clear that Black and minority ethnic staff continue to be underrepresented within academic levels within higher education. So one of the things I do in practice is to go around, encourage my colleagues, my people from BME backgrounds, so Black and ethnic minority backgrounds, to see whether we can work together to encourage them to make that transition from clinical practice to academia, really, because a greater proportion of students within universities, particularly within the UK, London in particular, there is a higher proportion of BMA students as well. And I think it's interesting for us to develop this partnership within ourselves to encourage and support individuals within BMEs to make that transition from clinical practice to be able to share their knowledge and understanding at the universities. We at the Uganda Nurses and Midwives Association are much looking forward to work with everyone else who's presented today, including colleagues from Cameroon and others, to be able to sort of move our objective forward. I thank you very much.
Thank you very much, Herbert. That was perfect. And we've got one last speaker, actually. Last but not least, we have Jackie Nanseko. She's a senior NHS midwife, interim board member of the Uganda Nurses and Midwives Association. And she's going to talk about diaspora evidence-based innovation in midwifery. And Jackie, as ever, if you can be timely, that would be very much appreciated. I'm wondering if we still have Jackie.
She's on. Okay.
Apologies for that. I didn't realize. I just want to say that greetings to everybody on the panel and all the attendees. It's such an honor to be able to present and to share with you. What I'd like to speak about basically is the fact that when you work in the clinical practice, I always believe that evidence comes from how we work. So my main ethos is to encourage as much innovation of skills and ideas in what we do. Part of what I'm going to share is basically to do with baby sleep. And the reason for that is mainly because before I went into midwifery, I used to work as what they call maternity nurse. And one of the main key things I found that parental sleep deprivation, especially for a new mom, affected her home, affected her marriage, affected her breastfeeding, basically affected everything around that woman who's just given birth. And if you had babies who are premature and like that, you find that the main issues that moms would really be struggling. And maybe it's not an area that we've really looked into, as in like maternal sleep postnatal. So that's basically how I started. Could we have the slides, please? Okay, so one of the research-based topics I looked at are flat baby mattresses ergonomically designed for neonates. And basically what I was looking at is, can you hear me?
Yes,
can you hear me?
Yeah.
Oh, brilliant. Okay. So basically what I wanted to look at is basically, are the mattresses that laying our babies on, are they ergonomically designed? So I really got into that research because when I was working in people's homes, that is before I became a midwife, one of the things that I noticed is that when you had a premature baby who had been discharged from transitional care, most of those babies were regurgitating a lot of mucus or their feeds coming back. And half the time we used to have to put them on sensors to make sure that they're awake and that they're alive. So that's how basically I came into it. So I developed basically, this took me about 20 years to develop. And it's called basically an easy breather. And the main ethos is basically something that would help in the hospitals in terms of breathing support for babies. They don't have to be in NICU, but it works very well in NICU as well. So one of the benefits I looked at is how does it support a brand new baby? And without going into much details, that was a background. So the optimum breathing position for a newborn baby, relief from excess neonatal mucus obstruction at birth, therapeutic body comfort, something that reminds the baby of being back in the womb, and also relief from infant reflux and colic and gas. If you go to the next slide, please. So basically the clinical benefits, as we can see, is that, like for instance, when you work on a postnatal ward or in NICU, one of the things that you notice is that when baby regurgitate, it really scares the mom. Now, if you have about 9 to 12 months to look after as a postnatal midwife, you still need to focus on this particular baby and you have so much going on. So what I was looking for is that something that when a mother places the baby on the mattress, they can actually get on with what needs to be done. And you as a midwife is supporting the moms how to prevent that regurgitation of that fluid coming out from the baby. Should we go to the next slide, please? So this is basically the standard mattress. I'll just go through because of time, but basically these are the mattresses we have. One thing I'd like to comment on a flat mattress, it does not really help a baby to be familiar with the way they've been sleeping in the uterus. So what I was looking for is something that emulates a baby. When a baby sleeps in a fetal position or the way they're used to sleeping in the womb, they actually settle. And as you can see from a flat mattress, it changes everything for them. So that's why half the time they'll scream, especially from about 6 p.m. in the evening, which we call evening colic, and onwards. If you're on the postnatal ward, you will know that, yeah, throughout the night, they'll be screaming. And half of that is just because of where we place them. Should we continue, please? So this particular, I usually volunteer my skills in Uganda, and I would strongly encourage all the diaspora nurses and midwives, if you can consider that as well, because you learn so much. I remember when I was working at Mulago volunteering, I delivered a 28-weeker, and basically you had to rush that baby into NICU. Now, at the time when I was there, you had to walk basically from the Ward 5C and go off to where NICU was, which is a bit of a trek. And you had to use the bag and mask to make sure that baby is okay. Because I know at that time, there were no incubators to transfer the baby from the labor ward. So when I got to NICU, we did not have any incubator for this 28-weeker. Fortunately, the APGAs had been very good. So I said, oh, just put the baby onto a hot water bottle. That's what we had. Basically, I'd produced these mattresses, we tried them. So I remember asking the CEO, deputy CEO, and the CEO of Mulago if I could donate some of those mattresses. And very kindly, they agreed. And the feedback we got is basically what we have in that paper, how they helped. And that's one thing that I basically want to consider is like, if only we could change the way baby mattresses are designed globally, it would save us a lot of time in the way we deliver basically our services, because babies, when they sleep well, they actually recover very quickly. Their oxygen levels, if they're NICUs, are not much, basically, they do so much for themselves just by the positional and brain development, health, and everything. Should we continue, please? So that's part of the report as well, which you guys can read later, if we can move on. So one of the things that I also noticed then back in for the UK, you would notice that sometimes babies would end up with flat heads. This goes everywhere, not just in the UK. But because in people's homes, part of my used to look after babies who are premature babies. The babies used to spend a lot of time lying down. That's what they do when they've just been discharged from transitional care. So sometimes you end up with flat heads. So I needed something that would basically support them. And that's how we came about the development. All the mattresses were designed with a brand new baby. So we started off with a 6-weeker. Don't ask me how, because that's part of our secret plan, whatever. But we started off with a 6-weeker. Then we went on with a 12-weeker. And then we went on with a 16-weeker and up to a 16-month-old baby. So we try out different levels to see how exactly, because my main concern as an innovator was to make sure that there would be no curvature of the spine, any risks and factors. Shall we move on, please?
Can I just ask Jackie, if in the interest of time, you can give us the highlights.
Yeah, so basically that's what I was going through basically. So those are the main highlights, just positioning a baby the way they're designed. If we go through the session, I mean, then that's it basically. So all those things basically how to position. And basically I'd say that's the end really. And so my ethos would be to encourage as much as possible for all of us to get into innovation, because we learn things when we're on the shop floor or the NHS shop floor, and it would be a really good idea. I'm really a great supporter of that. Thank you very much. I hope that's been helpful.
Hi, Helen, can you ask?
I think she's stuck. Hi, Ellen, I think we're done.
I'm back in the room again. Sorry about that. I'm just having some challenges with my internet. I just wanted to say thank you very much to all of our speakers. I think I share the comments that have been coming in, that everyone has found the speakers very inspirational and motivating. It's been very interesting to hear. I can't see the questions that are coming in on my phone. So I am going to ask if maybe Eugene could let us have some of the questions that could be put to the panel, please.
James, are you able to go through the
Yeah,
questions?
I'm more than happy to read them. But do we not have another speaker? Because I thought the idea was that we go through all the speakers, and then if there are opportunities for the Q&A, we'll do the question later.
I think if we have, I have it on my program for later, but if we have Jessica Fraser available.
Yes, hi.
Jessica, is it okay if you do your talk now?
Of course, yeah, definitely. If we're okay to share the slides, that would be wonderful. Yeah, and that slide is great. Thank you. So, well, thank you very much for inviting me to speak today. I hope everyone can hear me okay. It's been really wonderful to hear all from the panelists today, and I feel very lucky to hear such important discussions and innovations and hear what all the different groups and associations that are working together. I really look forward to going through my notes after this event and really take in and reflect on everything that's been shared. So thank you for that. My name is Jessica and I work for the Tropical Health and Education Trust, also known as THET. And I'm going to quickly introduce THET and then briefly touch upon the diaspora work we are now embarking on. So THET is a global NGO which has been working in the global health arena for over 30 years, supporting the training and development of health workforce and the strengthening of health systems in low and middle income countries. Since 2011, we have been the managing agent of the UK's largest health partnership programme. Next slide, please. All the work that has done is based upon the partnership model and health partnerships. So a health partnership is a partnership formed between a UK health institution, so this might be a hospital, a trust, professional association, or a health education facility like a university, and their counterparts overseas. Partnerships may involve 2 or more partners, but must be between institutions rather than just individuals, although a lot of these partnerships are formed as a result of personal connections. The aim of these partnerships is to deliver health workforce training and peer-to-peer support. If you just go back a slide, through utilising the skills and experience of each organisation. Partners co-develop programmes that address organisational and national priorities. The partnerships themselves are generally long-term and sustainable, while the projects which they deliver are discrete and tailored to specific identified needs. The aim of all projects is sustainable impact and mutual benefit. Next slide, please. In the relation to the diaspora work, we are now starting a new study and inquiry. This has been initiated from previous work we have done, such as our work looking at innovation, where we asked ourselves, how can the NHS learn from innovations that are emerging from health partnerships in low resource settings? Why are we not learning more from low resource settings? This led us to a public roundtable discussion about unconscious bias. Another of our reports, which was called From Competition to Collaboration, looked at how since the inception of the NHS in 1948, we have relied on a steady stream of professionals recruited from elsewhere. The report argues that the UK can no longer take for granted its status as a destination of choice for health workers, and argues that the UK's response to the global shortage of health workers should forge closer, more collaborative links between the health service and those in low and middle income countries in order to establish the UK as a trusted partner internationally. We understand there is still a lot we don't know, so we want to gain a better understanding of the involvement of diaspora in health partnerships. What is this partnership? What is the involvement in this partnership? How large is this involvement? The benefits that diaspora bring to health partnerships. We want to build an evidence base which can inform our work. This is particularly important when we are learning about how countries and health professionals around the world are responding to COVID-19 and how health partnerships are supporting each other during this time. There is a lot to be learned. We are prioritizing an inquiry and research study now to focus on how do health professionals in the UK who identify as diaspora benefit health partnerships. We are just at the beginning of this inquiry and have established a robust and experienced steering group to help explore and guide us through this work. Next slide, please. With this in mind, we'd very much like to hear from anyone who would like to contribute and hear more about the project. So please feel free to get in touch with me directly and explore more about this information I've mentioned and reports I've mentioned on the THET website. Thank you very much.
Thank you very much, Jessica. I don't think I've done you justice by, I don't think I introduced you very well. Jessica is a project manager with THET, the Tropical Health and Education Trust. And her talk was to look into an inquiry focused on the diaspora contributions to global health. And I think that she explained that very well. In terms of how the UK government is working with the diaspora in global health, as well as FET's contribution, we also have Professor Viv Bennett, CBE. She's the Chief Nurse and Director of Nursing at Public Health England, and she's the Director of Nursing at the Department of Health. So looking forward to hearing from Viv about how the UK government can work with the diaspora.
Helen, unfortunately, we had to read a bit earlier for another meeting. I don't know if you're still on the line.
Oh, okay. So Viv is not available.
Yes, she had to leave a bit earlier for another meeting. She just sent her apology.
Oh, okay.
Yeah, so I think the next step probably we can go through the question and welcome some more questions from the audience in terms of those.
Okay, yep, we will do that. Because we don't have our last speaker, we will be able to go straight into our questions and answer discussions. And I think it will be an opportunity for some of the panelists to be able to bring across some of the important issues that maybe they didn't get an opportunity to say within their allotted time earlier. We've got, I can see 71 participants on this call. So I'm wondering if we can see any questions.
Yeah, I was happy to help. I'm happy to read them.
Okay.
And also for the participants, rather than use the chat facility, if you could use the Q&A facility, that will help us to identify the questions. So one of them is from Ronald Jokindu, I hope I pronounced his name correctly. World Health Organization recommends professionalization of nursing and midwifery, which has been adopted by other countries in Africa. It appears Uganda is lagging. How can ANMU UK help in lifting the entry point in nursing to make nurses and midwives more competitive? Ronald.
Have we someone within our panel who would be able to answer that question?
May I try to respond to that?
Sure. Yes, please, Doctor.
Yeah. Thank you very much. I have to appreciate the person who has posed this question for the Ugandan nurses and midwives. I want to say that Ugandans, we had a time lag of when we started producing nurses at bachelor's level. It started late in 1993, and again, these nurses to access employment also has been delayed. Most of them, other than the nurses who are upgrading, most of the direct entrant nurses have not yet joined leadership position. However, that cannot be an excuse for Uganda. I think Ugandans have taken note that we need to professionalize the nursing and midwifery profession in the country. One of the limitations that we have had is having an association that has interest more on the profession than nothing else. And I also wanted to request that maybe we observe a minute of silence, remembrance of our late acting commissioner, Nancy, who was working very hard to see that this association is established. We feel that once that association is established, and within the nursing and midwifery leadership think tank, those are the issues that we have been putting on the board. How best can we make this profession of ours to the level of other countries? I want to say that we are not just sleeping and looking on. A lot is going on, because now many nurses have attained the bachelor's, many nurses have attained degrees. Now we have nurses at specialized level, at master's level, and a few at PhD level. But all in all, through this interaction, I've had research, a lot of innovation being presented. I think through this interaction with the Ugandan Nurses and Midwife Association in the UK and the Ugandan nurses this side, we have to work hand in hand to see that we support one another. I know it is a journey that we have to take, but I think this question and all the other intervention that is on board are encouraging yet and motivating us to take that lead. I want to say that we are on the right track. And maybe within 1 to 3 years, we'll be presenting another image and position as far as Uganda is concerned. Thank you very much, Chair.
Hey, Helen, do you want to read another question?
Yes, please.
There was another question which probably should have been answered together with the previous one, but here we go. It's from Christine Kakai to all the panelists. The bureaucratic hurdles for expatriate penetration are a challenge to navigate. The business fraternity, for instance, established a one-stop center to accelerate engagements. What such umbrella in healthcare or designated desk can enhance the diaspora and healthcare engagement? I think maybe for purposes of context, I'm aware that in Uganda, there is a one-stop business center where if you wanted to register your business, the URA is there, the Uganda Registration Services Bureau is there. So all the bits of the ecosystem are in one place and you can start very easily. I imagine that this is what Christine wants to, the question answered, what kind of facility exists so that the diasporans, there is just a one-stop center where they can find all this information and make their transition seamless.
Great, thank you. That sounds very concise advice. Are there any other questions?
Yes, they are. Do you want me to read them all and maybe the panelists can pick whichever ones they choose?
I think so.
Okay, the other question is from Jackie Matovu. How is this knowledge passed down into the community, especially here in the UK, where the Ugandan community has been heavily affected by COVID? And I think some of the events we've run in the past, it is very apparent, not just the Ugandan community, but basically very many African population, the African population has been adversely affected, and a lot has to do with lack of information and lack of engagement within our community. So that's Jackie there. The other one was from, I think that Sulaiman's question has been answered by His Excellency Peter Moto. The other one is about asking for slides. So maybe if we could answer those two questions and see how we're doing for time.
Helen, can I respond to I think one of the questions about how information or knowledge is disseminated within the community here in the UK. And I just
go on, because I was going to say something, but you go on.
All right, I was just going to add that that is actually one of the main goals and aims of the newly established Uganda Nurses and Midwives Association. That obviously we recognize that BME nurses within obviously those of Ugandan origin working within the UK, we may be unfortunate in the sense that sometimes maybe we have information that we don't have enough channels or the right appropriate channels to be able to share that information in really challenging situations, for example, the COVID situation. And I think one of the things that we are aiming to work as a group moving forward is to have centralized avenues for us to be able to share that knowledge, trickling down from either understand regulations, competency frameworks, for us to be able to share that knowledge as a group with our members, either through maybe training sessions, symposiums, or activities around continuing professional development activities, which can obviously enhance the knowledge and understanding of our members as well as improving practice. So I think this is something that as an organization, we're really very excited about. We want to be able to reinforce moving forward for us to be able to sort of share knowledge as we go along.
Helen, I wanted to respond at least partially to the question of, is there an equivalent of an organization that can help create a soft landing for the diaspora who are returning here, particularly in healthcare? I think that one of the challenges for Uganda is being able to map the existing contributors within this ecosystem. So you have the Uganda-UK Health Alliance, you have all the nursing associations, you now have the Uganda Nurses and Midwives Leaders think tank, And then we currently lack an umbrella for the Uganda Nurses Association, as my colleague, Dr. Safina, mentioned. So I think that if we can dedicate some time to be able, just as we needed to map the diaspora and link them together and identify the skill set and so on, we need to be able to do that within the healthcare system, I believe. When I first came back here, I sort of, if I didn't have a family that is very much well embedded into the healthcare system, I probably wouldn't have known what to do. You know, even just knowing where do you get a license, what is the process, how do you go about it, and so on and so forth. You have to be able to navigate that on your own. So I think that's a really important question to pose. And we at the think tank can go and think about it. But I would also like to ask our colleagues in the Uganda-UK Health Alliance to see if this is something we can work on collaboratively. Thank you very much.
Thank you, Dr. Rose. Helen, if I can just say something about the question from Jackie about how the knowledge can be passed down, and Herbert has really given some insight. Looking at my slide that talked about the next steps, we're looking at collaboration with partners, and some of them are already on this forum. However, we do have some, like shared previously, about different projects initiated by our own members. There's one given, you know, thinking about this COVID situation. Currently, there's a Diaspora International Hospital, a Uganda Foundation, which have set up to do a COVID crisis volunteering team. So they are reaching out to the communities. It is not easy, you know, it's volunteering work and everyone is in a lockdown, but it gives you an example of looking at the collaborating partners are both local and international. So within the community and outside. So I just wanted to share that, yes, the association's intent is to see how we actually spread the word within ourselves, but also gather the partners alongside who can help us achieve that on a larger scale. So thank you very much.
Thank you, Elizabeth, for that. That was great to hear. We may have a couple of more questions. I just want to ask the panelists, do you want to take a few more questions? Or do the panelists have questions that they want to ask each other?
Helen, I think we have a very good exemplar when Primerose was not able to share her institute collaboration. Yeah. And if there's a few minutes, please, because this is the link that we're trying to develop, how she was, how she managed to link, Moorfields Hospital to do great work in Uganda. So if that's possible, thank you.
I think to add on that, if she can do it quickly, we only have 5 minutes to wrap up.
Okay.
Yeah,
I'll be very quick. I'll be very quick. So yeah, as mentioned before, you go to the board. You want the decision maker to say yes. We signed the MOU to make sure that everybody does what they promised to do. And what we've had is one of the slides mentioned the enablers. So Uganda-UK Health Alliance enabled us to speak to the Ministry of Health and also engage. I'm here in the UK doing a full-time job. So they were able to get the meetings done, etc. And then we're now, with the help of Uganda-UK Health Alliance, we're engaging other people like Vision 2020. And what we've been able to do with support from Health Education England Global Engagement is get a bit of funding to start the nurse training, for them to become specialists. And this is one of the questions I would like to ask the colleagues in Uganda. When can we have that nurse practitioner training implemented? It's wonderful to have this platform and also to have some timelines, because we've got great nurses running camps. They've gone from zero ophthalmic training to doing, the screening themselves, running outreach camps. But when can they then be recognized as nurse practitioners, please? So that was one thing. And then the equipment, we're getting equipment from Moorfields. I think that's one of the other challenges. And this is where His Excellency and again Uganda-UK Health Alliance came in, and Health Education England. So that bit of funding, the bit of support and the strategic coordination was very important. But now we've got the channels through the nursing associations, Uganda Nurses and Midwifery Association UK, working with Uganda to make sure that we get these other things done quicker and efficiently. Thank you.
Thank you, Primrose. I'm glad that we made some time for you to be able to talk about your project, because it is indeed a really excellent one. At this point, I'm going to thank, in the interest of time, I'd like to thank all of the speakers today. I'd like to thank His Excellency Julius Moto for opening this very exciting meeting today. I'd like to thank Dr. Safina and Dr. Rose for their expertise in explaining how the diaspora can impact on home. And I'd like to thank the three colleagues, Rose, Wendy and Elizabeth, for sharing their experience of what they've learned. I'd like to thank Primrose, Herbert and Jackie for talking about how their experience of how diaspora can impact back home, but looking at sort of an academic and training initiatives. And I'd like to thank Jessica from FET for sharing with us how they're looking into how the diaspora are contributing to global health. We found this, questions and chat that was coming in from our audience was that everyone was finding this incredibly motivating. I, for one, have found it very exciting and informative. And I think that we need to really keep up this momentum and enthusiasm. And one of our speakers was saying that it can be quite challenging and a bit demotivating sometimes when things can take a long time. And I think from listening to our speakers, things can take a while, but it's important to move forward and keep the faith and make some progress, as all of these people have done. I think the other thing that I've got from this is that collaboration, working together, not just working in isolation, is vitally important. So I think if that's one of the key take-home messages I've picked up, and I think it's important for people who are sitting on their own thinking, how may I contribute? Get in touch with the other organisations for support, advice, and moving your ideas forward. So at this point, I think before my Wi-Fi lets me down, I will call this meeting to a close. And thank you very much for the panelists, for the audience, for your enthusiasm and passion. So thank you very much.
Thank you so much, Helen.
Thank you, Helen.
Thank you very much.
Thank you, Helen, and thank you for all the panelists.
Participants.
Thank you for participating.
We'll
make our slides available. Thank you, participants, and thank you, panelists. Thank you, SSCG, for hosting us, Excellency, our patron.
Thanks, Elizabeth.
Thank you, Safina and Dr. Rose, for taking time out, and Helen. Thank you, everybody.
Thank you.
Looking forward.
And good to meet you all. Thanks, Helen, for doing a fantastic job. That was good.
That was excellent modulation, and thank you everybody who contributed. Really good meeting everyone. Take care.
Wonderful. Bye.
Thank you. Bye.
Bye.
Oh,